Now, again, looking at the 4 pillars of treatment for heart failure, you mentioned the target dose. Could you just clarify what this means in practice?
So for 3 of the 4 pillars, we normally start below the target dose, and then we have to build them up. One of the pillars called an SGLT2, there only really is one dose, so they start on the optimal dose from day one. The other ones are normally built up sequentially over a couple of visits. So, we have a starting dose and then a target dose that we're trying slowly to get to. So in some of these other pillars, you might start on a quarter of the target dose, and then maybe go up after a couple of weeks or a month to a half a target dose, and then eventually to the full target dose. So again, you have to remember that heart failure doesn't just happen in old patients. It predominantly happens in elderly patients with lots of things wrong with them, but it also happens in very young patients, kids, teenagers, young adults. So we have very different types of patients, from very young, robust people to very elderly, frail type people, and not all of them can tolerate a full adult target dose the same. We would try to get them all towards it, but their ability to tolerate it is different between certain cohorts. And this is about, again, individualizing our approach to treating them as an individual as they come back to clinic, as they start the medicine.
You also mentioned young patients. Could you say a bit more about this?
So heart failure typically is a long-term consequence of lots of other diseases, so coronary heart disease, diabetes, atrial fibrillation, hypertension, anemia, things like this. So in the majority of patients, the large majority, is associated with later life and multi-morbidity. But we can get genetic variants and other causes of it as well that happen sometimes in earlier life. So again, this goes back to shared decision-making. What your elderly 90-year-old with lots of comorbidity and a different stage of life, what they want from treatment, what they want from life, might be very different to a 20-year-old who's right at the start of their life, who might not have other things wrong with them and is hopefully looking up for decades down the line into the future. Now, neither is right or wrong, and there's no right answer, but in real life, some of these patients might want slightly different things from their treatment.
Interesting. And are there any important drug-specific considerations that prescribers need to bear in mind?
So some drugs are water-soluble. Some drugs are fat-soluble. So the way in which your body is made up, again, different people are different shapes and sizes. Some people have more adipose tissue and are obese. Some people are very skeletal and thin. So where these drugs go in your body, how they're distributed, how long they are retained within your body, can be quite different from patient A to patient B. How your body excretes them, metabolizes them, and passes them out of your body are often affected by things like your liver and your kidney function. So both the components of the makeup of somebody's body habitus and their other organ functions might mean that, and within a class of medicines, you're better looking at drug A rather than drug B. So once you get more knowledgeable, more skilled, more experienced in heart failure, you can look at a class of drugs like beta blockers, where some are hydrophilic, some are lipophilic, some are very selective to certain receptors and reduce things like heart rate more. Some are less selective. The side effect profile of them can be quite different, because the lipophilic ones sometimes cross the blood-brain barrier and cause different types of side effects. So again, you have to look at the patient in front of you. There might be a drug that is your kind of go-to drug if you've got no other great considerations, but sometimes, and especially as you get more elderly, we have to try different combinations or different drugs within a class. There's also sometimes slightly different evidence within different drugs within a class. So if you look at things like MRAs, spironolactone and eplerenone, both great drugs, but the cohorts that we ran the studies in were quite different. So one in quite symptomatic patients for spironolactone, one in less symptomatic patients or post-MI patients for eplerenone. We can also have difference in side effect profile between medicines. So again, spironolactone causes a side effect called gynecomastia, which is breast tissue enlargement and pain. and eplerenone doesn't. So again, there sometimes can be a reason why you might pick one drug within a class rather than another. So we shouldn't just go through this like an automaton and a robot saying, well, it's this drug for this lady, this drug for that lady, this man, and it's always the same. You treat the patient in front of you, and you have to tailor the choice of the agent to the characteristics of that patient.
Well, from what you've described, patients could end up taking quite a lot of different medicines. So is adherence a problem for them? And if so, how can you help?
Adherence can be a problem, for sure. But adherence actually is a really complicated, kind of multifactorial thing. So again, if we go back in time, people thought, I'm the doctor, the healthcare professional, I tell you what to do, you go and do it. That assumes lots of different things. It assumes that you understand what's wrong with you, you understand the instructions, you understand the pros and the cons. So that's a kind of educational type component. It assumes that you want the treatment and you've some motivation to take it. You've chosen to take it. It assumes that your life is structured in a way that as you have to take 10, 20 different treatments all throughout the day, that you can align your life in a way that allows you to take them. We all know if we've had antibiotics that very few of us get to the end of a 7-day cycle, right, with the last one taken exactly when it should be. Life is not that simple. So we have lots of socio-economic barriers to medication adherence, where perhaps people have other life pressures, perhaps they have to go and work, perhaps they have to care for folk, perhaps they have other health concerns. Perhaps they can't afford treatment if they're in a part of the UK or a country where they have to pay for treatment. So people might get side effects as well. Maybe that stops them from taking their treatment. So the important thing with adherence is going back to basics. Do people understand things, and do they want the treatment? And that shared decision making. If that is yes, then we have to look for, well, what's stopping you? Is it something about your life? Is it something about cost? Is it something about another health conditions? Are you depressed? Are you cognitively impaired? Have you GI problems? Are you vomiting things back up? Can you not read the labels? Do you speak in another language? Can you not understand the directions that are there? Are you frail? Can you not pop things out? Is it so complicated that you need structure, maybe, in a weekly box? There's not a singular intervention which is the right intervention. The best way to do it is to speak to the patient, assuming we understand and you want it. What are the barriers? How can we help? Let's go through them. So adherence can be a problem, but it's a hard thing to solve. The way to solve it is you have to get to know and get a relationship with your patient. Again, a long-term relationship with between a healthcare provider and a patient, be that again the GP, the community pharmacist, etc., and the patient, are the things that will improve adherence through a real relationship of understanding what the barriers to adherence are. That's the real way, and that's what actually systematic reviews and meta-analysis and heart failure would tell us. There's not a panacea to this. It's about individualizing care and the relationship with the patient.